World of Pediatrics. I'm Carolyn Merriman. I'm the coordinator of the course, and today we're going to talk about growth and development for children. So I'm following the PowerPoints that are on D2L for you, and so if you'll get your PowerPoints ready. But we can't talk about children and growth and development without looking at the developmental stages, and so I'm moving to the first PowerPoint. The development stages, as you can see here, list infancy, toddler, preschoolers, school age, and adolescence. And so those are the major categories, even though we can break down children in different ways. When we're talking about infants, I brought a little infant with me, we're talking about birth to 12 months or 1 year old. So birth to 12 months, and one of my favorite theorists is Erikson. Erikson talks about children's development. We also have Piaget, Kohlberg, and Freud chiming in. But with Erikson, which I kind of emphasize and sometimes have test questions on, Erikson talked about what the tasks are of childhood. So the first one is the infant. And when Erikson talked about the task for an infant, birth to 1 year old, he talked about trust. So at this stage, the baby is trying to learn to trust. Trust adults, trust whoever's caring for them. If the baby's needs are not met consistently, then the baby develops mistrust, and that is the counter for trust. So I always ask you as nursing students, what can you do to create trust in a child that might be in your care? What can you do to create trust in a child that's in your care? Well, when they cry, meet their needs. Maybe they're hungry, maybe they're wet, maybe they're tired. And of course, this is what we teach parents to do also through the concept of anticipatory guidance, or guiding parents to do something in anticipation of needs. So teaching is really important as nursing students as well. So trust versus mistrust is what we're looking for the infant. What about the toddler? Put baby back down on the lap here. Toddlers are 1 to 3 years old, and the toddler, their main job, according to Erikson, is autonomy. Autonomy versus shame and doubt. Now that's an interesting one. Toddlers is autonomy versus shame and doubt. Autonomy means that their favorite word is me or my or no, and we've all seen toddlers that assert themselves like that. And that is a normal stage of growth and development, and we want parents to know that because they think all of a sudden that their child is getting to be mean. But the way parents handle that toddler's stage might make a difference whether or not they come out of it feeling stronger or feeling like they're shameful, or maybe they've put to shame. So those are some of the things to think about with the toddler. So with the toddler, we think of the T, and we'll get into that later. But toddlers do throw temper tantrums, and they do have toileting. That's when they're being toilet trained. So how a parent handles toilet training can either make the little toddler, that 1 to 3 year old, feel accomplished or maybe feel shameful. Now let's go on to the preschooler. Now what does Erikson say about the preschooler? Well, this is a delightful age. According to Erikson, it's called initiative, and then of course the versus is guilt. So what does initiative mean? Well, the 3 to 5 year old is they love to play games. They're imaginative. Their world is full of make-believe. So when you're thinking about the 3 to 5 year old as a nurse, there's a few things that you have to think about. How can I approach them and help them understand without being fearful because of this world of make-believe? So we'll talk later in class, but medical play is really important, letting them handle the equipment and using their dolls to play and listen to their own heart, or the doll's heart and then their heart. So when you're thinking about preschoolers, think about medical play and helping them alleviate their fears. Initiative. Now what's the guilt about if they don't have that task met? Well, the guilt comes from them sometimes at that stage, 3 to 5, maybe a new sibling is coming on board, and they may feel very guilty about, having bad thoughts about that little baby. And certainly if something were to happen to that baby, like SIDS, sudden infant death syndrome, they might feel like it was their fault. Again, they have magical powers, so that's what they think. The next stage is the school-age child, and some people call it young school age and then older, but we kind of group it together as a 6 to 12-year-old. And Erikson talks about the 6 to 12-year-old as the stage of industry. Now, industry is meaning something industrious. When you think of the word industry, you think of maybe a factory making things. Well, for a school-age child, it is having a sense of accomplishment, maybe in schoolwork, maybe in sports. They're very highly competitive and industrial. Okay, so the school-age child is, according to Erikson, industry. And industry means that they are competitive, they work hard for school, and that gives them a sense of accomplishment. Now, if they do not meet that task, then the versus for industry, according to Erikson, is inferiority. Inferiority means that they've not had that ability to accomplish things. So industry versus inferiority is Erikson's stage for these school-age kids. And finally, the last stage of development is the adolescent. The adolescent is identity, and then that's what the positive thing is, and then the versus is role confusion. So this, the adolescent is trying to figure out, who am I? What are my life tasks? How do my peers fit in? How do my parents fit in? What am I going to do for myself as a career? That's identity. And then the role confusion comes if they're not supported and they don't know exactly what they're going to do with their life. So this is just the basics of, with this slide, these developmental stages according to Erikson. And then other, like I said, there's some other developmental theorists that go along with this. What we see in the next slide just talks about all the areas that can be assessed in children. Sometimes we look at, when we're doing like a head-to-toe evaluation, we look at fine motor skills. Can they pick up things? We look at gross motor skills. How are they growing biologically? Sometimes we look at just their weight patterns and their height patterns and weight gain. Have they met or mastered their language skills? So when have they started babbling as a baby? And then when are those words forming? And then after that, when are they putting sentences together and then whole paragraphs together? So language development. Then the mental or cognitive, how are they growing in that regard too? And that's where Piaget comes in sometimes and talks about cognitive development. Social means how can they interact with others. So of course with babies, their first interaction would be with their caregivers. Do they make eye contact? Are they smiling? Do they have that social smile within that 2-month period of time? And then of course the emotional is also important as well. How are they growing emotionally? So all of this content that I've just gone over is also in your textbook, both the Wong textbook and also some of your ATI resources. Those first few chapters in ATI talk about growth and development of each of these stages and certain things that go along with it. Well, a couple of things that are just standard for when we're talking about development would be that it is predictable. Even though children develop at different rates or at their own pace, it is predictable. That means it is head and to toe. So that's why you would expect with a baby that they start learning to hold their head up first before they find their feet or before they can sit up. And then they find their hands and put them in their mouth before they find their feet and put them in their mouth. So that is predictable, and it is also head to toe. So head to toe means basically has to do with how kids' nerves are and how myelinization occurs. And so we know it occurs from the brain down. So as the nerve endings of the baby become more integrated, then the child is able to do these predictable head-to-toe kinds of things. We do know, though, that growth and development is influenced by many factors. And certainly whether or not a child has enough food or is in an environment that's stimulating for them versus a child that is in poverty and does not have enough food, for instance, could be a reason why they may not grow at the same rate. And if they learn, if they learn one skill, then they can build on that and build other skills. So, for instance, if a child has learned to hold a rattle, then eventually they learn to pick up a Cheerio, and then eventually learn to grasp a ball and be able to throw a ball. So even that motor skill, one skill is based on the other. Another example would be a child that has learned to sit up. Then after they've learned to develop those muscles, they may turn themselves over and actually pull up to a sitting or to a standing position. And after they get that mastered, then they can start taking steps around a table and finally let go and take a walk. So that's an interesting way of looking at development. One area may dominate. So you might see that the motor skills may dominate before the child picks up language, or language skills may dominate first and they may be a little bit slower. All of those are considered within normal. So why do we need to know growth and development? What do you think? Why do we need to know growth and development? It's because we need to look and see if we know kind of the norms for different ages, then we as nurses can say, wow, that's a red flag, and I need to refer that child because they may be out of the normal range. So we're going to look at each area just a little bit further, and each one of these slides are pretty self-explanatory. I don't need to read every one of them. That's why I kind of went over Erikson with you. But infancy, a couple things that are important for you to remember, and I've often seen these tested on ATI and NCLEX and possibly on my own tests. But you kind of need to know that the weight of a baby doubles by 6 months, and it triples by 1 year. Now, why is that important? Well, you would want to see if the child is measuring up to a normal pattern of weight gain to make sure that they can be fully functioning. So doubles at 6 months and triples at 1 year. Now, are you going to be asked to know exactly what the weight would be on a kind of a question? No. For instance, if they weighed 6 pounds at birth and they were only 10 pounds at 6 months, the kind of thing you would say is, what's going on? You know, what should I do with this? So if you have a baby that's 6 pounds and then it was only 10 pounds at 6 months, you'd say, maybe I need to do a nutritional assessment with that parent, or see, you know, really what the child's being fed, and go from there. That would kind of guide your nursing interventions. Also, just to kind of keep an idea that, you know, babies are kind of it's like physical bodies. Their little bellies are protuberant. They've got kind of a barrel chest. So their respirations are more abdominal. So as you're looking to look at a baby's respirations, just look at their belly. And of course, it's going to be very fast, but that will help you not trying to look at their chest, but more of their belly. Here is a couple things also that's important. Of course, we always are looking at the baby's head. And at 1 year, it continues to grow, and as you can see that the brain weight is 2.5 times bigger than it was at birth. So an important intervention that we do with babies, we always do head circumference from the time they're born really up to 2 years old. We want, every time we get a hold of a baby, we're going to measure their head circumference, and you'll be practicing that in your simulation and in your clinical. But that's an important thing because the brain is growing. And what do we know about babies' brains? Well, they have suture lines and fontanelles, which means that the brain cavity is not closed or restricted, it has the ability to expand and grow, which is awesome. The other thing important is that we have the fontanelles. Now, I always think about fontanelles as the anterior fontanelle. I've still got my baby with me here. But the anterior fontanelle is, you find it by just following the suture lines back. And the top one is the diamond shaped. It's the largest. I always think of L. It's the largest, and it takes the longest to close. So it closes in about 12 to 18 months. So that's a particular one. It should be flat and soft. If you follow back the suture lines to the back of the head, right about in this area, you're going to find a triangular shaped fontanelle, and that's called the posterior. That one is smaller and it doesn't take as long to close. So you might see that one closed even by the time the child is maybe 2 months old, so 6 weeks to 8 weeks. You want to look, of course, at the symmetry of the child's head and that type of thing as well. But those fontanelles are important. Now, why is that important to note? Because if you have a fontanelle that closes too soon, then that's going to restrict the baby's brain growth. Versus if or if you have one that's really giant and that's not closing, maybe that child has some kind of fluid on the brain or hydrocephalus or something else going on. When a baby is born, we also know that it has a very high respiratory rate, and we also know it has a very high heart rate. So those two things are pretty high in a newborn, and as a baby grows, what we see is that the heart rate and the respiratory rate, as they go through childhood, those two things kind of go down, and the blood pressure, which was low, goes up. So we have something called vital signs trends in children as well. Okay, this is just talking a little bit about nutrition on the next slide, nutrition and digestion. It's interesting that the baby gets some iron from the mother up to 4 to 6 months, and that's important. And of course, if the baby were breastfeeding, that would be a really good way to continue getting that mother's nutrition. But they don't have a very mature digestive system, so that's why we don't want to put solid foods in their body until they're ready. So it's important that you wait, and this is part of the anticipatory guidance. We teach families, don't be force feeding babies before they're ready. So about 4 to 6 months, that GI tract starts to come together, and that's when maybe you can start adding some solid foods. Again, talk about anticipatory guidance and add some solid foods. The first one, of course, that we would add would be something that's least allergenic. And that least allergenic for a baby would be something like rice cereal would be a good start. But don't tell parents not to, before that time, to start solid foods. The other thing that makes this important for babies is that they have something called an extrusion reflex, and that's where their tongue keeps pushing things out. So if a baby's pushing something out with their tongue, they don't want food to come in. So it's called an extrusion reflex. It goes away about 3 to 4 months. That makes sense. Then about 4 to 6 months, usually they say 6 months, you can just be with formula or breast milk. But then you might want to start having the parent add a solid food. One at a time, it would be a good idea. The next slide just kind of combines some of the milestones that you would see, and you've got more specific than that in some charts in ATI and also in your Wong book. There's some wonderful charts on growth and development that I would refer you to in your chapter on health promotion, especially in Wong. But this just kind of gives an overview of that age range as far as when they start sitting up or when they start sitting by themselves, and we'll go more through that later. This psychosocial behavior, we've already talked about Erikson's trust versus mistrust. And remember, the intervention for you as a nurse is meet these kids' needs consistently and and promptly in order for them to trust you. So if I were the charge nurse, how would I take care of this? Well, I might assign the same nurse to a baby the whole time that they're in there so that they have that trust and not that fear going on. A couple of challenges that babies have. One is called separation anxiety, and the other one is called stranger awareness. And both of these are considered challenges that we see with infants. And separation anxiety starts about 6 months. It gets really intense, 9 to 1 year, but it's where the child is very much aware of who their caregivers are, and if they are separated from their caregivers, they might react by crying or being really stressed. So that's something to let parents know. And if you have a child in the hospital and they're already anxious, then you might want to tell the parent that one of the ways they can help the child is to make sure someone that the child knows stays with that child as much as possible. The cognitive development slide really focuses on Piaget, and it just reminds us that they are children. The infant starts with just reflexes, and then the reflexes start more into voluntary actions, and then with repetition and mastery, more motor skills are developed and they can explore their environment. And we will go over reflexes later, what the primitive reflexes are for children. But Piaget said basically that kids have to, as infants, accomplish 3 different things. That they have to separate objects from the environment, so knowing that maybe that they are separate from like a toy, that objects have permanency, so as a kid gets to be 6, 7, or 8 months old and you hide a ball under a blanket, they'll be able to pull the blanket back and say, oh, there's the ball. So they understand that it has permanency. And then they start understanding symbols. Without seeing them, they kind of understand symbols, like maybe they hear their bottle being mixed or something and they look for it. So thinking of an object without seeing it. But those are 3 accomplishments that Piaget talks about. Separating objects from the environment, object permanency, and then also starting to understand some symbols. We know bonding is a big issue for infants, and so that's why as soon as a baby's born, they try to put it on the mother or have the mother breastfeed, but bonding is a very big issue. So if a child has to go into the neonatal intensive care unit and is separated from the mother or the father, then that can cause some detachment. We also can see that besides separation anxiety, there is a term called stranger awareness or anxiety, and that's where the child knows who is familiar and who is not familiar. So a child that has stranger anxiety might cry when you, the nurse, comes in the room if they've never seen you before. So here's a hint. If you've got a baby that's a little older, past 6 months, 7 months, or 8 months, and or a toddler, both those that all the way through that group of children, as a nurse, instead of marching in right up to the child, an approach would be, let's go through the parents. So let's talk to the parents, sit down by the parent, get a little history, and then let the child kind of see, oh, this person is talking to mom or talking to dad, they seem pretty safe. And then they will more likely, with just gentleness and calmness and a slower approach, let you then maybe listen to their heart or talk with them or do a little bit without so much anxiety. So that is a principle that we do as far as approach. As far as language goes, I mentioned it, but kids first learn, they just cry. They're very newborn. Newborn is usually considered up through 1 month. That's called a neonate. And eventually that crying starts becoming babbling, and then vowels. At about 2 months, you start hearing the cooing, they talk about it. And then the cooing becomes more consonants by 4 months. You expect by 4 months that they're starting to respond to their name. And then by 6 months, they they can say no, respond to no. They don't say no. And then sometime between 9 months and 12 months, you might hear that first word. They say that the D consonant, da, 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 which gets excited for dads, but that's a consonant that comes out first. And so the dad will say, well, they said my name first, so they must love me more. So another thing we talk about with children is temperament. What kind of temperament does this baby have? And you can almost see in a newborn nursery some kids that just sleep through everything and others that are just wide awake and looking around or very excitable. So the temperament of a child is important to know because sometimes parents adjust to different child's responses. So they say that there's these 3 different titles. An easy child, I don't know if I like exactly when it says easy to difficult, but an easy child is that child that is even-tempered, they're easy to take care of, a very positive approach. Secondly, it's the slow to warm up child. They have a little bit more time in social situations, they're a little bit more moody. And then they use the term difficult, which means this is the baby that is hard to settle in, they're highly active, more irritable and negative. Now, I don't think we should stereotype kids, but these are the different temperaments that they say, and how a child has a temperament might determine a parental response, especially if you have a young parent that's just new at this and doesn't know how to take care of a baby. So that's important to know. Again, as a summary slide, the common developmental issues for infancy would be separation anxiety, and then stranger fear or awareness. These are the things that are things we can work on as nurses through our approach. All right, so the next stage, or the next group of children we want to talk about is the toddlers, and they're awesome little guys, but sometimes challenging for parents. So when I think of the word toddler, I think of the acronym PRAISE, and that's what you have on your slide. So the P, if you're thinking about toddlers, 1 to 3, the P is for the fact that they are growing, their bodies are growing, and so they need push-pull toys. Those are the ones where you see them pushing a little cart, but they need that because they're learning to walk and getting steady on their feet, so push-pull toys are really awesome for that. The other thing that is a P is called parallel play. So what is the play for children? Well, for, of course, infants, it's the sensory motor where they have music and mirrors and that kind of thing to stimulate their minds and their visual, and that's why parents use rattles and music. Well, for toddlers, they are more into what we call parallel play. If you look at 2 toddlers, they can stand side by side, but they don't interact really well with each other because autonomy, they're trying to have this war of me or my. So for toddlers, parallel play means that I will play next to you, but don't expect me to share my toys. They're not ready for that yet. So that's called parallel play, side by side without a lot of sharing. The R for praise talks about rituals and routines. And one of the things we have to do as nurses is we have to ask the parents when we're doing a history, what does your child usually do at home? That is a wonderful question that will help us so much because we want to try to mimic in the hospital as much as we can that ritual and that routine. So when do they eat? When do they take naps? Do they have a bedtime routine? What are their favorite toys? All of those things are really important in order to help maintain that child's life in a less stressful way. One of the things that we talk about for children is called atraumatic care. And atraumatic care is without, means A is the prefix that means without, so without trauma. So in peds, we're trying to minimize the physical and also the emotional trauma that kids go through. And we know that when children go into a hospital, they can experience regression. So regression is Another R for the toddler. If you have a toddler that's 3 years old and they were potty trained, maybe putting them in the hospital in that unfamiliar setting is going to cause them to start wetting the bed again. Or maybe they don't want a bottle, but now they're asking for a bottle. So that is called regression. Now the A that we talked about is Erikson's autonomy versus shame and doubt. And we want them to experience as much as they can on their own within safety and guidelines. So if they want to do something for themselves, or I do myself, then letting them do that without putting them in a situation that would be unsafe, because safety is a big concern for these little guys. And then they do have accidents, and that's part of the potty training that we go into. The potty training involve the parents. I already mentioned atraumatic care. I mentioned anticipatory guidance. Pediatrics is also family-centered care. You have a child, and you have a child within the context of a family. So involve the parents, especially with these toddlers. Like I said, if you're coming in the room to do a history, don't you jump right up on top of that baby or that toddler. You want to hold back, talk to the parent, and let the child say, oh, that's a safe person, and go from there. And then S is the separation anxiety we talked about. It's still present in our toddlers. E stands for elimination, and that is the elimination toilet training, and also they're exploring their worlds like crazy because they've got 2 feet that work now. So they can explore their environment, they can climb up on cabinets, climb stairs. I just want to put a side note, that makes them very dangerous as well. So some of the concepts we talk about with kids is also, their growth and development, but also what are the things that we need to protect them from. And so, of course, for toddlers, it's falling into swimming pools and climbing up on cabinets, or burning themselves on fireplaces, or drinking chemicals that they may see out. So exploration can also mean safety problems. So what are the toddlers doing? I already said they're into me and my, but they do need praise. Am I okay, Mom? They look up for parental reassurance, and they continue until about age 2 with this sensory motor stage. Well, let's look at their bodies. 2.5 years is basically 4 times their birth weight. Wow, they're really growing at this point. They gain about 4 to 6 pounds per year, and they're also getting really tall. Remember that you're still measuring their head circumference up to 2 years old, and from 2 years old up to 2 years old, that head circumference should be about the same as their chest circumference. They still have kind of barrel chest, but they also have little big bellies at this point, especially the 2-year-old. So potbelly appearance, their physiological system, all these nerve connections I was talking about are trying to come together. They are learning voluntary control of elimination. They're still working on it. And there is something that's going on. So they go through baby all the way to toddler. They have something where their rate of growth is slowing a little bit. And there's a term for this, and it's called physiological anorexia. So what is physiological anorexia? Well, this is the stage where the parents are going, oh my gosh, this child only wants to eat macaroni and cheese. So it's where they're slowing their growth down and they're becoming very picky eaters. So it's called physiological anorexia. About 15 months, for sure, they should walk. I said that it starts earlier than that. 18 months, they can run and fall easily. 2 years, up and down stairs. Back a little bit, 15 months, they should have by 9 to 10 months, they start picking up Cheerios. And by 15 months, they should be able to drop pellets into, like raisins, into a bottle, or throw objects. By 24 months, which is about 2 years, circular stroke if you gave them a crayon, or a vertical line. So those would be some things to look at. This is, of course, the stage we talked about is autonomy versus shame and doubt. And it's hard because they're very negative sometimes, and you have to sometimes, if they're having a temper tantrum, the parents will go, what do I do? They're having a temper tantrum. Well, they get easily frustrated, so sometimes you can just ignore them if they're having a temper tantrum. Sometimes you need to pick them up and hold them and let them know that they're safe. They can tolerate separation longer, but they do protest when parents leave. Their thinking and reasoning is still pretty primitive. They kind of are self-focused or self-centered. So that's something to think about. They are aware of height and space, but they are, again, dangerous. So they may climb up on top of a cabinet or get to a chair. But again, if you have knives or something up on those cabinets, that's going to make them in a dangerous way. Because they're egocentric, they do not look at others' perspectives. They think that the whole world is centered around them, and they get very frustrated. So, another thing we might want to tell parents is not to take them out if it's their nap time or if they're hungry. They're bound to have a meltdown. They do sometimes blame inanimate objects for causing them problems. For instance, if they fall, they will hit the stairs and say bad stairs. They blame the stairs for making them fall. And so this is a stage where we can tell parents, instead of saying don't do this or don't do that, talk more positively, saying things like, well, it really helps me when you lay the ball down, nicely instead of throwing it in someone's face or something like that. But please don't throw your food would be something versus just saying don't, or no. As far as moral development, they don't really understand right and wrong, but they do see maybe that being bad means punishment and reward means good. They are starting to learn a little bit about simple prayers and the idea of God, if that is a philosophy of the family. And they can name some body parts. These little guys are fearful of intrusive procedures. So they may have had they've had some immunizations, and so they might be afraid of someone like, I'm in a white coat today, but someone in a white coat if they associate that with pain. All right, so starting to develop more words, about 300 words at 2 years old, starting to have less stranger anxiety. So that's interesting. Now, the common development issues with toddlers would be temper tantrums and negativism, and then toilet training. All of those are challenges for parents that we need to do some anticipatory guidance about, and not to, punish kids that are too automatically just because, that's their stage of development and that's what they're trying to do. We are ready for the preschooler, and the preschooler is a magical age. They're just delightful. So something between the toddler, where they're just me and my and focused, to this age of awareness where they start, learning and saying, why is this happening? But it's the age of discovery and curiosity. Remember, Erikson calls it initiative, really discovering their world. But I use the acronym MAGIC, and MAGIC is because, first of all, because they're fearful. They fear if they're coming into the hospital, they fear that they're going to be mutilated, that you might be, if they see one drop of blood, they think they're going to lose all of their blood. So what do? You use a magic Band-Aid over it. But they're afraid of their body parts being mutilated. The A is for the type of a play that they like. We talked about with toddlers, parallel play, side by side. But these preschoolers are associative play. They can start interacting and sharing their toys. They are also afraid of being left alone or abandonment. So this is another stage where they need some reassurance from parents, and if they have to be in the hospital, a parent should stay with them. They have also, we talked about initiative versus guilt, and I talked about the guilt being maybe that they've had bad feelings and something bad has happened. And then, of course, the initiative means looking for creative things to do. It's not unusual for this age to have imaginary playmates. I bet some of you had imaginary playmates too, thinking back on your childhood. But this is the stage where they might have an imaginary pal where you need to set a place at the table for that imaginary pal, or they talk about them a lot, and this is just very, very normal. And the C is for curious. Well, 5 pounds in a year for weight gain and 2 to 3 inches. They are better at running and jumping and walking and climbing. Of course, we still think about safety with these kids. If they're doing all these things, they may start, by 3 years old, by the way, they should be able to ride a 3-wheel bike. That's kind of a classic thing that I've seen tested before. 3 years old, 3-wheel bike. So walking, jumping, running, and climbing means safety again. We don't want them to be biking out in the street without a helmet or without parental supervision. These are some of the things, psychosocial development, that some of our theorists talk about, Erikson and Freud, and Freud's a little bit on the bizarre side, but about castration complex and Oedipus complex, and like little boys loving their mothers and that type of thing. Because they're magical, these kids have tremendous fears. They fear monsters. They fear ghosts in the closet. They fear that the equipment that you've got in the hospital is going to eat them alive. So once again, if you can have them touch and hold and play with this equipment and see that it's not going to hurt them, or do it on their dollies or their stuffed animals, that's going to help them get through the anxiety of being in the hospital. They're preconceptual in thought, and they're starting to develop a conscience where they're knowing, starting to learn right from wrong. Why? They'll ask that question all the time. Why is the sky blue, Daddy? Or why does the dog have a tail? And then they'll say something like, why is that lady's glasses so ugly? And of course, they'll do that right in front of the lady and embarrass the parent. But that's the kind of inquiry they have as a 3 to 5-year-old. They can tolerate separations longer, and they do communicate and interact very well. That's the associative play. They do have some sibling rivalry. Here comes the baby, and they're thinking all these thoughts about, I used to be the top dog, and now this baby's here. So they can care and dress and eat and by themselves. Learning a little bit more about family rules. They like to mimic and do things that Daddy are doing or Mommy's doing. Maybe clean up the room a little bit. So what are the biggest issues for preschoolers? Well, one would be their fears, and how can we engage with them and help them in the hospital with these fears. So think preschooler, think medical play. And then the other thing we have to watch for, since they're preschoolers, are speech problems. If you see a speech delay in a child that's 3 to 5, my thought to you would be, what would you do with that? If a child's not speaking well, then what other system might you think about assessing? And that would be hearing, and maybe some make sure that they can hear okay. And so test their hearing, and also test their vision. So how do you test vision with a 3 to 5-year-old? You all are looking at some of the ATI physical assessment tapes, but you can use a Snellen chart that's a picture chart to test for vision. All right, we're at the school-age child, and the school-age child, I look at the acronym DIMPLE, and this is the 6 to 12-year-old, and the acronym DIMPLE. So a couple of things. The D is because, and we're going to talk about chronic illness and death and dying later, but death. Children that are school age, they understand that death is permanent, and they have strong feelings about it. And certainly in our day and age, when children have been exposed to death through shootings in the schools and tornadoes that have hit recently, we know that children are exposed to death. And so how do they handle that, and how we handle it, and have they lost pets? That all affects their input. We also have the industry versus inferiority by Erikson. The M is for modesty. We see that especially like 5, 6, 7-year-olds, as they start to understand their bodies, they would like to be covered. There's some modesty there. P is for peers. Now, this is different with school-age kids. Usually, especially the early school-age kids, the boys like to be with boys, the girls like to be with girls, the same-sex peers. And they sometimes have clubs, like the boys will have Hate the Girl clubs. One of my kids had that. And then the girls will have their own clubs. The girls think that boys have cooties and are stupid. This is normal stuff for school-age child. In a hospital situation, the school-age child wants to have control. So loss of control can be a really big issue for them. They don't want to, they want to make sure that they are in control of what's going on. And they are more into concrete thinking. So what does that mean? That means that they need to see things kind of in black and white. So if you're the nurse of a child that's in the hospital, that's a school-age child, and they're getting ready for a procedure, they need detailed explanations. They would be great to have a picture, like for instance, if a child has to have a heart catheterization, show the child the heart, show the details, show how it's going to run through. Give that child detailed explanations with pictures or illustrations or models. That's what a school-age child needs, because they are concrete learners. There are growth spurts within the school-age period of time. This is when that first tooth is lost and they look kind of like silly. They call it ugly duckling stage. We also know that between usually 9, 10, 11, we start seeing some pubertal signs. Puberty begins, those surges in hormones. So there is something called the Tanner stages of development that I would refer you to as far as the sexual development of children. They're gaining some weight and height during this time. And those bodies that were rounded in toddlers are becoming more straight up, not quite such big bellies. This is, again, Erikson industry, and we're trying to help them accomplish things, self-esteem and self-concept. They do need peer approval. I told you Piaget's concrete operations, so they have more ability for memory and symbols. And this is a stage where school-age kids love to have collections. They might have coin collections or shell collections or baseball card collections, but they love to have things that they can order and trade. So that's an interesting thing. They like to group objects. They are aware of themselves. They're aware of children that have disabilities or that are different than themselves. More moral development here. They view God as something that's helping people. If that's within their family belief systems. They may say more prayers. They do sometimes see illness as a punishment for misdeeds. There's some religions that say that. They're more opinionated and make more judgments about moral things. But the moral code is what's taught by the parents. And they also know the difference between boys and girls and colors of skin. This is a time the 6 to 12-year-old, depending on how they're formed, can bully and become also the object of bullying. So bullying is a problem in the schools for 6 to 12-year-olds particularly. Again, they like the same friends that's same sex so that they can play with them and that type of thing. One of the things that's a problem with school-age kids is that they do learn to lie and steal and through their competition sometimes. So sometimes that industrious stage can make them vulnerable to that. So that's something parents deal with. You might have, and also cheating, by the way. So you could be playing a checker game with a school-age child, and if you start winning, the child will say, no, the rules have changed. You really can jump 6 times instead of just twice. So they're an interesting group to play with as well. But this is part of their role development and their moral development. So what are the developmental issues that are common for the school-age child? The fears of death and maybe violence because of all the things that we've seen in the schools and some of the shootings and that type of thing. School issues of bullying or doing well in school or not doing well. And then, of course, dishonesty, how to learn to be an honest individual. All right. Our last group that we're going to talk about is the adolescent. And the adolescent, we talked about identity versus role confusion for Piaget. Adolescents are awesome, and they're also very challenging as well for parents, because they're trying to they have formulated their own opinion, they're growing up. They have more abstract thinking according to Piaget, so they can look to the future and say, what am I going to do, and how is my life going to proceed? So they're struggling a little bit with, I need to be on my own. This group needs peers, and so their acronym that I've chosen to describe an adolescent is PAIRS. PAIRS, like you can always think of kids pairing together. So P is for peers, and of course their peers are the most important thing to them. Peers can be male or female, but they just need their friends. A is for alteration in body image, and they really need to, that's an important concept for them. So they may be in the hospital really sick with an infection, and they're more worried about the fact that, maybe the medicine's making their body swell. Or there was one young lady who was having seizures, and in order to do the test for her EEG, they had to shave little pieces of her hair. That caused more anxiety than the fact that she was having seizures. So those are some of the things, the alteration in body image. And then the I is for identity, trying to figure out who they are and what role they play. And then the S is separation from peers. If they have to go in the hospital and be separated from their peers, I'm thinking nursing intervention. Well, how can we keep them in touch? And if they don't have a contagious illness or vulnerable for infection, let their peers come in and support them. Get them a computer so that they can still be on Facebook and IM. And those are some of the strategies you'll see the child life specialists do with our teenagers. So adolescence begins 11 to 12 years old. It goes through 18, maybe through 20. Again, the puberty is a wide range, but girls do mature earlier than boys. And again, I want you to review the Tanner stages. You had them exposed to you in Jarvis, but you also have the Tanner stages in your Wong. The hormonal activity is what activates puberty. And when we talk about endocrine later in the year, we're going to talk about precocious puberty. But generally speaking, puberty is pretty orderly and occurs in the same rate for boys and girls. I mean, the same way for boys or girls, but girls are about 2 years earlier than boys through the process. So what is this identity about and independence? Well, the psychosocial development means that we're helping them achieve their body image, and young adolescents are also trying to establish a value system, and they are definitely in that process. Career decisions, what am I going to do? Am I going to go to college? And then emancipation from parents, and that's hard for some parents to do. They need their peers intensely, and so if they don't have friends, it's also an emotional time because they feel isolated. Mood swings are there, and I guess the other thing about adolescents, I would say, are risk takers. They are risky in their behavior, but they need and want limits, so it's quite a contrast. Future thinking and abstract thinking, just like the toddlers, though, they're very egocentric. They think the world revolves around them. And of course, body acceptance and peer acceptance is probably the most important for body image. They look for adult models, and so if parents are not responding appropriately, or parents are drinking and smoking and saying don't drink and smoke, then they're seeing parents as hypocrites. So they really do look for adult role models. And then they also, this might be the time where they question and challenge how they were raised spiritually. So I used another acronym. I had two. This is anticipatory guidance for adolescents, and I use the term spaces because sometimes they need a little space to breathe and away from their family. But the S I thought about is anticipatory guidance about smoking. Certainly, there's all kinds of things you could smoke, but smoking, and also the fact that the self-worth issue. Some adolescents, it kind of is it develops as school-age kids, if they didn't have self-esteem, then it can also come over into adolescence. The P is for recognition that there's still a lot of pot out there and peer pressure to do things that they may not want to do, and also some planning for their future. I just put alcohol down as an A. I'm sure there's others that you all can think about. For C, I put down the need for like maybe chaperones and curfews and issues about chastity. All those things can be things we can think about with teenagers. E is exercise, and then S is safe choices. And, you know, again, teenagers think they're invincible. They think that nothing will happen to them. But that's why they have the crash cars around prom time on the parking lots of schools, because they want to remind kids that if you drink and drive, that you can end up dead. So sometimes you have a shock effect for teenagers, but helping them make safe choices about their relationships and their driving habits and their drug and alcohol use, and that it's okay to say no to all of those things is appropriate when we're teaching teenagers. Some of the common developmental issues for adolescents would be peer acceptance, their fears about whether or not they're going to be accepted, and also limit setting. It's okay, again, for parents to say you need to be in by 10 o'clock on a school night, or even not even have them go out. But limit setting versus saying, you know, the world is yours, do what you want, I'll see you later. I mean, just, you know, so parents need to set limits. So what we have talked about today is just basic growth and development from children from infants all the way through adolescence. We've kind of framed that with Erikson's stages of development and the tasks of accomplishment for each age group: the infant, the toddler, the preschool, the school age, and the adolescent. And then we've also talked about the common developmental issues for each of these stages. So this concludes this portion of growth and development. Thank you very much.